The utility of transplant has been evolving over time in ALL. The traditional indication for allogeneic stem cell transplant in ALL was patients who had Philadelphia positive ALL and for patients who failed to attain remission. And that could be MRD, or that could just be patients who relapsed or were refractory to disease. However, this has changed dramatically over time, particularly as we've had more and more different subtypes and higher risk groups that have been identified, and also some more effective therapies which may make transplant less necessary. Transplant is most effective in several groups of patients. First of all, any patient who has MRD positivity after induction or at the end of treatment, whether they receive salvage therapy or not, those patients definitely need to move forward with an allogeneic stem cell transplant because they will most likely relapse otherwise. Patients with certain high-risk types of ALL, and to name a few, in the T-cell ALL world, early thymic precursor T-cell, acute T-cell lymphoblastic leukemia, ETP ALL, is a very high-risk subtype. All of those patients should be referred for stem cell transplant. And any patient that has had relapsed disease after they initially attained remission, even if the remission was MRD negative, those patients should move forward with a transplant. There are also some other high-risk groups: mixed lineage acute lymphoblastic leukemia, Philadelphia-like acute lymphoblastic leukemia. These are other types of ALL that can be considered for stem cell transplant, among others.